Dr. Zulfia Oktanida Sharif, Psychiatrist, Dr. Hafid Al-Gristian, Psychiatrist, Master of Law, and Dr. Karina Kalani Firdaus, Psychiatric Resident, Faculty of Medicine, Universitas Indonesia, and all of the participants. A very warm greetings to each and every one of you. I am Zahra Ibadina Silmi, the Master of Ceremony of this event. On behalf of the organizing committee, we extend our appreciation for your presence today, especially for all of the participants who attended since our first international webinar. Praise to Allah, Lord, the Beneficent, the Merciful, so we can gather here all together in this wonderful event with wonderful speakers and participants. Welcome to Indonesian Early Career Psychiatrists and Indonesian Psychiatrist Trainees Association joint event, second international webinar, Building Resilience Through Existentialism, Idealism, the Reality and the Capacity in Transition Era among Psychiatrists in Low and Middle Income Countries. And this topic for today's session is the future of psychiatric practice with digital technology. The digital revolution has reached the world of mental health. Prominent examples include the rapidly growing use of mobile health applications, the integration of sophisticated machine learning or artificial intelligence for clinical decision support and automated therapy, and the incorporation of virtual reality-based treatments. Specifically, in this webinar, we do highlight the current unmet needs that emerging technologies may be able to address, summarizing what digital health can offer for assessment, treatment, and care integration, and describing some of the challenges and some new direction for innovations in this field. This webinar will be started with an opening remarks by the chair, Dr. Zulfia Oktanida Sharif, Psychiatrist, and after that, there will be a presentation from IndoECP representative, Dr. Hafid Al-Gristian, Psychiatrist, Master of Law, a presentation from IPTA representative, Dr. Karina Kalani Firdaus, Psychiatric Resident from Faculty of Medicine, Universitas Indonesia. Responses from Professor Norman Sartorius, MD, PhD, Fellow of the Royal College of Psychiatrists, and Dr. Natalia Widyasi Raharyanti, Psychiatrist Consultant, Master of Medical Education. And after that, we will have a Q&A session, photo session, and the last but not least, closing statement by the chair. So, let us now start our webinar by welcoming Dr. Zulfia Oktanida Sharif, Psychiatrist, as our chair today, the Working Group Coordinator of IndoECP, to deliver her opening remarks. Let me read her curriculum vitae. Dr. Zulfia Oktanida Sharif, Psychiatrist. She was graduated from Psychiatry Specialty Program, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital, Jakarta. Now, she works as the psychiatrist and head of psychiatry unit at Tarakan General Hospital, Jakarta, psychiatrist in Pondok Indah Hospital, Jakarta, psychiatrist in Apotek Tomang Raya, Jakarta, and also a clinical tutor in Faculty of Medicine, Universitas Indonesia, and Universitas Kristen Krida Wacana, Jakarta. Without further ado, please welcome Dr. Zulfia Sharif, Psychiatrist.
Thank you very much, Zahra, as our Master of Ceremony for this evening's event. Good evening, everyone. I would like to welcome all of you in this international webinar. This is the IPTA and IndoECP joint event series. I believe this is the second series of the second event of the series with the global theme, Building Resilience Through Existentialism, Idealism, the Reality and the Capacity in Transition Era among Psychiatrists in low and middle income countries. And for this evening's event, our topic will be focusing on the future of psychiatric practice with digital technology. And today we will have two speakers representing IndoECP section and also IPTA. And then we will hear responses from Prof. Norman Sartorius and also Dr. Natalia Widiasi. For the first opportunity, I would like to welcome Dr. Hafid Al-Gistrian, Psychiatrist, Master of Law, as our first speaker. Dr. Hafid will have 10 minutes to give his talk. Dr. Hafid is a psychiatrist, graduated from Faculty of Medicine, Universitas Airlangga, and he is also a Master of Law and currently is a PhD candidate at the Faculty of Medicine, Universitas Airlangga, Surabaya. And Dr. Hafid, I will give you time, 10 minutes to give your talk.
Thank you, Dr. Vivi. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, good afternoon, and good evening. Thank you for the opportunity for me. I would like to share my presentation. Could the committee let me share my screen, maybe? Because I haven't shared my screen. Okay. Okay. Sudah terlihat, Dr. Vivi?
Yes, you should
Okay.
put in slideshow mode. Yes.
Okay. Okay, thank you. So I'm honored to be here in this fantastic event. I believe this international webinars is a place for us young psychiatrists to learn more from our seniors and colleagues. Dear Prof. Norman Sartorius, who has always been an inspiration for us Indonesian psychiatrists, our teacher, Dr. Natalia, Dr. Dia Setia Utami, and all seniors, Dr. Sati, Dr. Viv Sharif, and IndoECP colleagues, Dr. Karina Kalani, Dr. Leo, Dr. Zahra, and all IPTA friends from Indonesia for all university. This evening, I would like to share about what we do in our educational institution, the use of virtual reality in clinical practice. Of course, this is a pilot project. We don't have any clinical results yet. We still in develop to try this on research studio. And this is our point of discussion. I hope this won't last more than 10 minutes. And this is our current project about phobia desensitization, meditation, and mindfulness training. We use virtual reality and mixed reality. The first one, we learn and try make some modeling from popular apps. As you can browse in your Google apps, you can find self-pause as tools for mindfulness training. So we try to make the 3D visuals so we can implement that in our Oculus tools, Oculus Google. This one, we try to make some validation. We try to learn about the 3D models and what the benefit and what is the risk for a patient. And then we try to make some module so our patient can try this as the alternative of the therapy. And this one is when we try to implement the phobia training, phobia desensitization training. This one when we create the module for acrophobia, for the highness, fear of height, when one of our IT team try for the module we make the 3D visuals. And you know what I feel when I try this Oculus Google? I feel dizzy, and our IT team feels nausea and almost vomit. So this adverse effect that we try on healthy subject must be aware of, because we will try this method for psychiatric patients. Of course, we don't want to worsen their mental mental condition. We don't want when they try this method, they more worsen the mental condition. So we try to find any research protocol and treatment protocol from few journals, and the few journals also told about the same thing about the adverse effect, about the indication and contraindication, when this method only good for few patients who should be in maintenance phase, not in acute phase. So we should try to answer that, is it this method is good enough for the patients or not? If this method's only good for the maintenance phase, of course it will be only cosmetic method. So we try to make some models or more good for therapy, of course, when we try to mix between ideal or standardized therapy and this new method of virtual reality therapy. And of course, we should understand more about the adverse effect or benefit effect or therapeutic effect when we try to mix this new method with the standardized method. Of course, I cannot be alone. Of course, we have to discuss with the expert of the field, and Mr. Sukaridoto is assistant professor. He is an engineer in electrical engineering. This latest research is about visual therapy, visual model for health, including for phobia, desensitization, and mindfulness training. And we try to develop this protocol for the research. The first one, we try to learn and make some model from the existing apps and websites. And we try to make not a single application. We mix the website-based module. So everyone in every country can access this website. Of course, should ask permission from us, and then they can use the website for Oculus therapy, for the virtual therapy, for phobia or mindfulness training. So when we try to make these models, we should understand gap between the research and therapy outcome, and we should review the ethical clearance, so we minimize the adverse effect and maximize the therapeutic effect for the patients. And then we try to make the scenario about how we place the environment, how we design the realistic environment when we try to implement in 3D module. And then we try to ask our peer and expert for validation about this virtual environment. Is this is good enough or not? And we try to implement in healthy subject voluntarily, so we understand about their experience when using this 3D module. And then we use these result and feedbacks for ethical review and clearance again to refine our method. And then we try to make some treatment protocol. The second phase is not yet implemented, but we ensure that the method is safe enough for patient when we try to this method to non-healthy subject, to psychiatric patients. And but we realize, we know that there is still some adverse effect that we should anticipate for the patients. So we should must be clear for the ethical implementation for the patient's experience when they involve in our experiments. And that's all. This is a take-home message for us. We know that technology is well developed, and of course, this is very potential as added value for psychiatric therapy. Right now, I say this is an added value. And added value never replaces traditional psychiatric treatment. As you can see, when we try to make some phobia desensitization training, it's still using exposure therapy as we used in behavior therapy for phobia cure. We should understand that this technology never replaces medications. We should know that every technology is only facilitation, and we should ensure that the technology is for the therapy success, not for to make another adverse event for the patients. And if we want to develop something out of the box, we need to willing to build networks with experts outside the psychiatric fields. And we understand that clinician as a leader, we are psychiatrists as a leader in the therapeutic fields, but we still on par with other experts. We should give some respect for them. We should be open-minded. We should understand our strengths and weaknesses, and be willing to taking responsibility in research on paper and even in the field when we try to implement in the clinical practice. And last but not least, the future is ours. Thank you. Good evening. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Amazing, Dr. Hafid. Very wonderful presentation. It's very insightful to see your work using the virtual reality in clinical practice. And for the second talk, we will invite Dr. Karina Kalani Firdaus. She is a psychiatric trainee at the Faculty of Medicine, Universitas Indonesia, and she will be the representative of IPTA as a public relations coordinator at IPTA. Dr. Karina, you have 10 minutes for your talk.
Okay. Thank you very much, Dr. I'm going to share my power presentation. Give me a while. Okay. Good evening, Professor Norman Sartorius, my Dr. Natalia, Dr. Sofia Sharif, and fellow residents and fellow psychiatrists. Can you see my screen?
Yes,
Okay.
very clear.
Okay, thank you very much. So today I'm going to actually just share my experience as a psychiatric resident during the transition from offline psychiatric practice to digitalized psychiatric practice in Indonesia. So first, I would like to talk about the issue that led to this transition to digitalized setting. There are two issues. The first is the progress of technology, and the second is the pandemic. Regarding the progress of technology, there is an increase in use of communication through digital technology in the past decade. Not only that, you can see that there's an increase of social media usage causing a transition of way of communication more to virtual. Due to that, there's a shift of communication to a virtual setting. Regarding the pandemic, due to the social isolation due to quarantine that was enforced worldwide and also locally, where in Indonesia we call it PPKM, there's a forced quicker transition to this virtual setting. The effect of pandemic in Indonesia due to the restriction of community activities and also the increase of COVID patients led to some effects. The first one is decrease of social interaction, especially in hospitalized COVID patients. The second is decrease of direct access of psychiatric services, especially regarding psychotherapy. And the third one is increased psychological distress due to stressors related to the pandemic. This effect causes that there's a need. What needs is the bridging of communication between patients and family and also healthcare providers, the need for screening of psychological distress due to COVID, and also a more accessible access to psychiatric care and services. Locally, and at our place, we came up with a solution. The solution is a transfer of psychotherapy and other services through teleconsultation. And the second one is called, locally we call Pojok Sahabat, that I will explain more later. Regarding telepsychiatry in Indonesia as a resident, we perform in three main activities. The first one is our routine psychotherapy on patients, while still prescription is still done in the clinic. And the second one is when we talk about cases, we do scientific activities, we also use telepsychiatry. The third one is telecounseling for peer residents, especially for residents outside of psychiatry. Regarding the routine psychotherapy and in scientific activities, it was performed in patients who needed routine psychotherapy, but with little to no access to offline psychotherapy in a hospital or in a clinic. This was done with appointment and also agreement with the patient, both with a written agreement also. And regarding recording, it was only done by consent and also explanation regarding the reason of the recording of psychotherapy. For the documentation, it was stored only by the therapist safely. And also, we also wrote a protocol of the psychotherapy, which is documented for further supervision. And in some instances, we had direct supervision with our consultants. Regarding telecounseling for peer residents, we shared about this, and it was a lot of residents actually contacted and registered, and it was performed by residents with a competence for counseling and psychotherapy without the need for direct supervision. And this is the activity that we performed in our hospital, in Cipto Mangunkusumo Hospital. We call it Pojok Sahabat. I didn't change it into English because if I changed to English, it would be a bit weird. In English, it would be a friend's corner. And it's a psychiatric service that was targeted for families of hospitalized COVID-19 patients at Cipto Mangunkusumo Hospital, with the aim to educate patients and also bridge communication between family and patient. The registration was performed daily and only on office days, where we facilitated video calls between family and patients that didn't have gadgets in isolation, and also communication between family members and health practitioners. We also perform psychoeducation and supportive psychotherapy for families. And also we did a screening for psychological distress. One important thing is we also had a monthly case presentation and an evaluation through virtual meeting. Why is this important? First, it's important to maintain supervision and also quality control of our psychiatric services. The second one is also important, is to ensure the safety of residents and consultants. At the first half of the pandemic, we did perform partial telemedicine. So some of our residents had contact with the family of the patients, COVID patients, and it had a risk of increased exposure to COVID. Due to our monthly evaluation, we come up with another solution, which we transitioned to a full telemedicine. And this also kept the safety of our residents and also consultants due to the decrease of exposure to COVID. I also performed a quick survey where 33 psychiatric residents filled the survey regarding the telepsychiatry experience and also comparing about online and offline psychotherapy in our hospital. 3 people out of 33 residents actually performed telepsychiatry before the pandemic. This is an evidence about what I said before, that actually telepsychiatry wasn't something that only appeared because of the pandemic, but it was always there before the pandemic. And I also asked about the preparation between offline psychotherapy or online psychotherapy. And most 79% actually preferred offline psychotherapy. Why? It was due to a better observation, better therapeutic interaction, and also a better way of building relationship with the patient. 20.6% actually preferred online psychotherapy. This was due to better in flexibility of hours and also place. And also there are some patients that preferred limited interaction. The most common challenges of telepsychiatry was mostly internet issues. There was almost 91%, and also difficulty in assessment and therapeutic relations, and also difficulties of patients in using gadgets, although a majority already had gadgets. Okay, my last quote is telehealth leaves us with no excuse not to find the help we need, both for body and also for soul. So no matter where we in the world are. So this is my closing statement regarding telepsychiatry in residence. Thank you very much.
Thank you, Dr. Karina. A very wonderful presentation. So we have already seen different aspects of using digital technology in providing clinical services in psychiatry, like what Dr. Hafid has presented previously, that he used the digital technology in treating patients with phobia. And Dr. Karina has also presented about her work with other residents during the pandemic, providing psychotherapy to patients. And for our next event is we are going to listen to the response from our experts. First, we are going to hear a response from Professor Norman Sartorius. And I believe that everyone has already known Prof. Sartorius. He's very well known in psychiatry, and his CV is very long, so I won't be able to read all of the CVs of Prof. Sartorius. Prof. Sartorius specialized in neurology and psychiatry and obtained a master's degree and also doctorate degree in psychology. Prof. Sartorius has published more than 400 articles in scientific journals, has authored and co-authored a number of books. He is also the president of the Association for the Improvement of Mental Health Programs. And Prof. Sartorius is also an honorary member of numerous professional associations and advisory boards, both national and international. So we are very lucky to have Prof. Sartorius with us this evening. Prof. Sartorius, the time is yours.
Thank you very much, and thank you for inviting me. And thank you also. I want to congratulate the initiators of the notion that early career psychiatrists would meet on every few months to talk about various things, present things to each other, etc. And I think it's a wonderful use of the new technology to do that. It is not harmful to anybody. It doesn't take too much time for those who listen. It gives an opportunity to those who prepare the talk to not only prepare the talk for others, but also to review a little bit their knowledge and to know themselves what they have done and what it looks like when you speak about it. Because sometimes we tend to work on and forget what it looks like when you are from the outside. So my congratulations for this. And now to today's topic. I think that one general rule which I would like to mention, which is I think that we are currently in a danger that we might become slaves of technology. Technology is wonderful, and it can be very helpful to ourselves, to patients, to society, to everybody, but it must remain a servant of people, not a master of what we are doing. And unfortunately, we are seeing that quite a few people, in fact, see and accept the rules of technology as if they were more important than the rules of people who are informed. Now, I think that the description of how to, whether to use virtual reality or not, has been done very well. And I think that it's important to recognize that virtual reality is just another new treatment which means it has to go through all of the stages that a new treatment has to go. It has to go through the treatment of expert consensus, then development of the method, testing out on healthy people, etc., etc. All of the things that have been well described. But then you have to ask yourself, why am I doing this? What is the limit? Because in the beginning, in the pilot phase, you will discover that results of this new method may be mediocre. And here is the big question then, whether you should then continue doing it and developing it, or whether you should drop it and say, it's over. I don't care about that. It's not good enough for me. And I'm saying this in view of the fact that although Indonesia has made wonderful progress in training a number of psychiatrists, it still has very few psychiatrists. And the hours that you have at your disposal are, because of that, very precious. One has to think a little bit of how many people there are who have mental illness and who could be helped by relatively simple techniques that you already have at our disposal. So the question is, if I spend 6 hours looking and thinking about how better to do virtual reality, how many patients did I not see because of that? Maybe 6 hours, I do not know. When I was a young psychiatrist working in a country where at the time there were very few psychiatrists, I was seeing between 15 and 20 patients an hour because there were so many and very, very few. Now, I do not know how many patients you normally see in Indonesia now, but I wouldn't be surprised if you see maybe up to 10 people in an hour, or maybe more when you are when it's a busy place, which means that for 4 hours of psychotherapy, for virtual psychotherapy, you have in fact not seen maybe 50 people. And that is the equation that is unfortunately present for all of the people in the developing world, where the resources are extremely scarce, and particularly scarce are your brain resources. How do you use your knowledge and your skill and your capacity in order to be most helpful to your people and people who are around you? So that's a question which one has to think about. Now, I think that what is very important about the study which you are doing is that it will help you undoubtedly to learn techniques of assessing treatments, very useful thing, because you'll have to apply this. But there is one very important point which is sometimes neglected, and that is how good the results must be in order for me to continue doing this research. Because you will find that if a particular treatment is helping a very small, is effective, but helping only a very small proportion of people, it's almost not worth continuing, because once you have done it with great effort, it will be only a very small proportion of the total load of patients whom you had before you who will be there. Now, research that you have described has one other useful feature, and that is you do research with other people, your colleagues. And it's nice to have a contact with your colleagues in addition to having a cup of coffee, also in building something together, studying something together, helping one another to understand things. And I think that that is not a described advantage of research, is that it is allowing the people who do the research to get to know other colleagues and to grow in friendship with them. And that is something that is helpful as well. It strengthens your links with your colleagues and with people who are doing this research together with you. Once you've developed it, it's just joint, it's a common baby. Everybody is the father, and it's very nice for the mother. And it's very nice to have this experience of having created something jointly with other people. Now, so I think that I will now say a few words about Karina and her work, because I really think that it is a wonderful illustration of when we should think about internet technology in psychiatry, which she has given us by saying, we have done it because of COVID. Because COVID had the consequence that people could not leave the house. And because of that, we are not sufficiently in link with other people. And therefore, the notion, let us try and find a method in which we can help people, although we cannot see them and cannot get to them, is a wonderful motivation and a very good decision to take. The question then will be, now that you've developed it, will you continue doing it? Or will you say, all right, now that the COVID is over, I don't know, I hope that it's over, will you still continue not seeing people? I mean, one of the great attractions of psychiatry is, in fact, working with human beings, sitting together with a human being whom you can see and who has so many things to tell you which you do not see on a screen. You do not see whether people are sweating. You do not see whether people are shaking their leg. You do not see what they do with their hands. You very often, the fine refinement of the voice is disappearing. The artificiality of the conditions is such that it's maybe not so good. So all of these things are also very important. For you, therefore, the question is, if you develop the technique that it works very well in COVID, will you then use it in non-COVID? Or will you then say, all right, now I have a tool in my cupboard. If ever we are forced not to see each other, I can take this tool out and we can use it and help people and help ourselves. Or will you say, now I have a new tool, I don't really want to see patients anymore. I'll sit in my office, switch on the television and the computer, and when I have enough of a patient, I switch him off. It's a decision which probably has to be made. So on one hand, I congratulate you for having done what you've done, and I hope that you have developed knowledge which will help you to help people at the distance, while at the same time remaining aware of the importance of being in direct contact, particularly in psychiatry. What patients in general want is very often not advice. It's very often not a treatment. For most patients, one of the most important features is what Frank and others have called the non-specific aspects of treatment. The non-specific aspects of treatment are suddenly the patient is respected, somebody listens to him, you are willing to, when the person comes through the door, you are willing to stand up and offer him a chair, make him a human being again, because many of them have been treated for a long time in a very inhuman way. And having a bit of privacy for a patient, having a possibility to maybe, in addition to being in treatment, also get some other means of regaining self-respect. Maybe sometimes it is more valuable to bring a hairdresser to a lady to do her hair, than to have an hour of psychotherapy, because the changed the appearance that she had might be helping her to feel better with her children, to feel better with her husband, to feel better with herself. So I think it's the non-specific aspects of treatment which are the key. And the non-specific aspects of treatment until now have not been transmittable by screens. They really require your presence. They require real life. And so I think that wonderful that you develop a tool, use it when you need it, but at the same time remain a psychiatrist who returns dignity to patients and gives them support, advice, ideas, and helps them to remain human despite of the illness. So much for me. Thank you very much, Madam Chairman.
Thank you very much, Prof. Norman Sartorius, for the response. This is a very insightful response, something for us to think about the the presentation that Dr. Hafid has presented about using virtual reality, digital technology, we need to consider whether it's worth the time, the work compared to our daily work as a psychiatrist, seeing many patients in a day. And also what Professor Sartorius has also pointed out about the providing psychotherapy or psychiatric interviewing during using the digital technology is not something that is going to replace the existence and also the connection between psychiatrist and the patient. So hopefully we are not replaceable by technology. Hopefully psychiatrists are not replaceable. All right, we are going to move forward to our next expert response. We are going to hear response from Dr. Natalia Widiasi. I'm sure everyone here also already know Dr. Natalia, Dr. Natalia Widiasi Raharjanti, psychiatrist, consultant of forensic psychiatry. Dr. Natalia is a lecturer and the head of psychiatry specialty program at the Faculty of Medicine, Universitas Indonesia. Dr. Natalia, you have 15 minutes to give your responses to both Dr. Hafid and also Dr. Karina's talks.
Thank you, Dr. Fisha, for the warm introduction. Good evening, everyone. Senior and Prof. Norman Sartorius, thank you for the opportunity for me to join this event. First, I like to tell the big appreciation for Dr. Karkal and Dr. Hafid's presentation, because through their presentation we could see that the telemedicine and the VR development for the phobia treatment as the advancement in technology during pandemic COVID is a momentum that we should see as an opportunity to improve our psychiatry services in Indonesia. But according to, we already listened from Dr. Norman Sartorius, despite all benefits and benefit from this opportunity, we also should be aware of the pitfalls and also the challenges for something new that we are still developing here. Responding to Dr. Karkal, when using telemedicine, we see that the readiness of our facility, like supporting technology, and then our technology literacy as a psychiatrist when doing telemedicine, and also our patient literacy about technology is also something to consider about. Like Dr. Karkal already said in the slide, that internet also still a problem in Indonesia. So when we have not limited technology or we have limitation in that, actually this using digital technology to our practice supposed to be something that provide us to optimize when we see the patient could be potential danger for our patient, such as when we talk not clearly because of the internet, they could misunderstand or something. Our sentence could be not hearing clearly, so the patient could criticize, or maybe some conflict, medical legal could be happen when we don't make the supporting technology is ready for our services when we want to apply this technology. for telemedicine, also we should consider about the ethical challenges, such as which patient is considered eligible for the using telemedicine when we do psychiatric practices, such as patient with high risk or with emergency psychiatric conditions such as agitation or suicidal thought or action. It could be not eligible for this kind of psychotherapy that we do, but not all are not eligible for this telemedicine. During COVID, we see that telemedicine could help our patient, especially with patient with so many comorbidities, or when they are afraid come to the hospital, and also when the family already infected with the COVID and they cannot see us, our patient cannot see us. Telemedicine does help and does showing benefit for us, but this must be clear. Everything should be ready to support the technology, support better, and our patient already have good literacy to use the technology to help they could better interaction with us, because rapport is very important when we are practicing psychiatry, and the technology cannot replace that. And according to Dr. Karkal, even in her survey, said that the patient choose better face-to-face interaction compared to the telepsychiatry that we have in our practice in COVID. But this could be not because of the survey, so we could close the telepsychiatry. I think we could develop more better with providing the good technologies, services, or supporting and make the better education, or selected the people who eligible for the the patient who eligible for these services with telemedicine. And then one is more important also, the privacy aspect for the telemedicine, such as our medical record. When we still develop all the this technology, we should aware how to make the data is secure, or the link is secure, only could be accessed with the authorized party, not everyone could join the data for this kind of patient with and then for the Dr. Hafiz, I think one is the question is because the virtual reality is still under development, and we still have limited data about the side effect or contraindication for the patient using the virtual reality for the phobia. I think we should continue to having feedback from the people who use this virtual reality to optimize the development of your virtual reality device, so we could optimize all the technology that we have as one of tools that will help people with phobia, because virtual reality have excellent from the study said that it could replace that when we do behavior experimentation, we cannot do in vivo, so virtual reality can make it like experience in real situation, such as when they have phobia with fly or phobia with height. Yeah, that's the strength of the virtual reality. But according to we have still lack of information, we still have lack of knowledge about who could eligible for who's patient eligible for this kind of intervention. I think what we should see is still continuing getting feedback from the patient or from the volunteer who join this module, your module. I think your module is good, but we still see that as a good doctor, we should understanding for the basic psychological changes that may occur during virtual reality therapy. And then we should also carefully screening the patient. This patient is already ready for the exposure or not, because when they still in acute condition and they cannot compose their emotion when they are getting panic when in this reality, or is when they are having reality testing ability defect, so it's not eligible for this kind of intervention. So choosing the right or eligible patient, carefully screening patient is a must for this kind of intervention. And understanding the side effect and contraindication for using VR is also the need of for the our practices, and taking standard precaution prior to the treatment is also one we should consider about, like we should prepare our patient before doing this. They know what will they going through, and then what should they do when they feel panic. So we should try give them a skill to relaxation or a muscle or breathing or something when they get panic. Or you should also maybe try to check the readiness for the patient to deal with the new situation before we involve them to this exposure. I think that's my response for Dr. Hafiz and Dr. Karkal, Dr. Sylvia. Thank you.
Thank you, Dr. Natalia, for your response. Dr. Natalia has reminded us the need to consider several aspects in using virtual reality to patients who need therapy, and also for psychiatrists who conduct telepsychiatry or telemedicine practices to their patients. And perhaps we need to be more careful in screening patients to know whether it is suitable for their condition. I believe Dr. Natalia mentioned about, for example, like acute condition, or whether it is eligible or not for receiving treatment through telepsychiatry and other aspects as well. And I believe we are going to discuss very lively about these topics, because as young psychiatrists and the future psychiatrists in Indonesia, of course, we need to be more aware of the development of digital technology in our services. But we are going to see a video showing of IPTA before we open the Q&A session after this. So committee, you have time to show a video from IPTA.
Assalamualaikum warahmatullahi wabarakatuh. Dr. Eka Herentizain, SPKJ, founder IPTA pada saat masa residen di Fakultas Kedokteran Universitas Hasanuddin, dan saat ini sebagai advisor IPTA di tahun 2022 dan 2023. IPTA atau Indonesian Psychiatric Trainees Association adalah asosiasi residen psikiatri se-Indonesia yang didirikan pada Februari tahun 2022. Dan IPTA ini dapat didirikan berkat support dari IFPT atau European Federation of Psychiatric Trainees di tahun 2019. Dan sejak didirikan, IPTA tergabung dalam WNPT atau World Network of Psychiatric Trainees. Networking dan kolaborasi dimulai dari masa residen menjadi hal yang penting dan bermanfaat di era digital sekarang ini. Keberagaman pembelajaran dan pengalaman klinis serta akademik di 9 center pendidikan psikiatri di Indonesia itu menjadi suatu kekayaan yang bila mana dapat dibagikan secara luas merupakan kesempatan yang besar bagi para residen untuk mengembangkan diri baik secara personal maupun profesional. Ditambah lagi, IPTA membuka kesempatan yang luas untuk berjejaring dan berkolaborasi dengan residen-residen psikiatri di luar negeri, dan hal ini memungkinkan pertukaran ilmu pengetahuan dan kolaborasi di tingkat internasional. Kami percaya bahwa psikiatri adalah profesi yang ilmunya akan terus berkembang ke depan, dan hal ini tentunya menuntut sumber daya manusia ataupun psikiater yang secara individu dapat maju dan memiliki wawasan yang luas secara profesional. Oleh karena itu, IPTA adalah kesempatan yang besar untuk mengembangkan diri di level nasional dan internasional untuk tujuan tersebut. Salam sehat jiwa.
Assalamualaikum warahmatullahi wabarakatuh. Salam kenal, saya Dr. Era Catur Prastia, spesialis kedokteran jiwa. Saya sebagai advisor dari IPTA periode 2022-2023. Tujuan didirikan IPTA adalah untuk menyatukan residen psikiatri seluruh Indonesia dalam wadah kebersamaan dan kebinekaan. Tugas saya sebagai advisor adalah memastikan agar program kemudian kegiatan dari IPTA ini sesuai dengan visi dan misi dari IPTA. Yuk join bareng IPTA, luaskan jaringan dan perkenalkan psikiatri Indonesia ke seluruh dunia. Wassalam.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, Shalom Elohim, Om Swastiastu. Saya Leonardo, saya residen psikiatri dari Fakultas Kedokteran Universitas Indonesia, dan saya adalah Presiden-elek IPTA tahun 2022-2023. IPTA atau Indonesian Psychiatric Trainees Association memiliki visi agar residen psikiatri Indonesia memiliki daya saing secara global. Adapun untuk mencapai tujuan tersebut, kami menghargai dan mengakomodir berbagai teman. Kami juga membangun jejaring secara nasional dan internasional, serta mengencourage untuk transfer ilmu pengetahuan di bidang psikiatri dan menginisiasi komunikasi, advokasi, dan kerjasama antar organisasi. Dengan jumlah anggota lebih dari 100 orang dan jumlah center 9 di Indonesia, kami siap untuk membuka peluang kerjasama secara global dan internasional.
Assalamualaikum warahmatullahi wabarakatuh. Salam kenal rekan-rekan PPDS Psikiatri seluruh Indonesia. Perkenalkan, saya Rehan Maditra, residen psikiatri dari Universitas Indonesia, sebagai Vice President IPTA tahun 2022-2023. Tugas saya adalah untuk mendampingi Presiden dalam menjalankan fungsi eksekutifnya, serta membantu dalam proses administrasi dan networking IPTA. Sejauh ini, IPTA sudah berkolaborasi dengan berbagai organisasi, baik secara regional, nasional, maupun internasional, dan bertujuan agar menjadi wadah residen psikiatri di seluruh Indonesia dapat berbagi pengalaman dan menjalin kerjasama.
Assalamualaikum, salam sejahtera. Perkenalkan, saya Stephen Iskandar, residen psikiatri dari Universitas Pajajaran. Saya adalah sekretaris dari IPTA untuk periode tahun 2022 sampai 2023. Saya bertanggung jawab dalam bagian administratif seperti korespondensi, pelaporan dan pengarsipan, dan juga pengelolaan keanggotaan IPTA dari teman-teman residen psikiatri di seluruh Indonesia.
Assalamualaikum warahmatullahi wabarakatuh. Salam kenal rekan PPDS Psikiatri di seluruh Indonesia. Saya Aulia, residen psikiatri dari Universitas Hasanuddin. Saya adalah bendahara di IPTA, di mana tugas saya bekerja sama dengan pengurus IPTA dalam penyelenggaraan anggaran, melaksanakan administrasi keuangan, mengarsipkan laporan keuangan, mengelola, menyimpan, dan mengeluarkan keuangan IPTA untuk usaha atau event divisi IPTA, mengembangkan promosi usaha via media sosial, serta mencari sponsorship untuk kegiatan IPTA. Terima kasih.
Assalamualaikum warahmatullahi wabarakatuh. Salam kenal kepada seluruh residen psikiatri di Indonesia. Saya, Zahra Ibadina Silmi, adalah residen psikiatri dari Fakultas Kedokteran Universitas Airlangga, Surabaya. Saya merupakan koordinator Public Relation dari IPTA. Public Relation adalah salah satu divisi di IPTA yang bertujuan untuk menjalin dan menjaga kerjasama antara residen psikiatri di Indonesia dengan berbagai organisasi dan komunitas kesehatan mental, baik di dalam maupun di luar negeri. Harapannya, seluruh residen psikiatri di Indonesia dapat semakin meningkatkan kesempatan untuk dapat berkolaborasi dan bekerja sama dengan berbagai pihak, baik dalam kancah nasional maupun internasional.
Assalamualaikum warahmatullahi wabarakatuh. Halo rekan PPDS Psikiatri di seluruh Indonesia. Perkenalkan, saya Dianda, residen psikiatri dari Universitas Pajajaran. Saya adalah koordinator Community Services di IPTA. Community Services adalah divisi yang bertujuan untuk mengakomodasi kepedulian IPTA kepada masyarakat melalui berbagai kegiatan, baik berupa pendidikan maupun kegiatan lainnya. Bentuk kegiatan yang dilakukan berupa seminar atau live singkat secara online dan membuat materi edukasi melalui media sosial agar mudah diakses oleh masyarakat. Terima kasih.
Halo teman-teman PPDS Psikiatri di seluruh Indonesia. Saya Karina, residen psikiatri dari Universitas Indonesia. Saya adalah koordinator Research Division di IPTA. Divisi riset merupakan salah satu dari divisi IPTA yang bertujuan untuk mengembangkan wawasan dan kemampuan di bidang penelitian serta pendataan publikasi, termasuk instrumen yang sudah divalidasi secara nasional maupun internasional bagi anggota IPTA. Melalui divisi ini, kita berharap dapat mengakomodasi kebutuhan residen dalam meningkatkan kemampuan meneliti dan memajukan pelayanan evidence-based practice di Indonesia, terutama di bidang kesehatan jiwa.
Salam kenal pada semua PPDS Psikiatri di seluruh Indonesia. Perkenalkan, nama saya Karen, residen psikiatri dari Universitas Airlangga, Surabaya. Saya adalah koordinator Education and Development di IPTA periode tahun 2022-2023. Education and Development bertujuan untuk meningkatkan pendidikan residen psikiatri di luar kurikulum akademik.
Assalamualaikum warahmatullahi wabarakatuh. Salam kenal rekan PPDS Psikiatri di seluruh Indonesia. Saya Nia, residen psikiatri dari Universitas 11 Maret Surakarta atau UNS. Saya adalah koordinator akademik dan training di IPTA. Akademik dan training adalah salah satu divisi di IPTA yang bertujuan untuk saling bersinergi menambah wawasan dan keterampilan bagi residen psikiatri Indonesia.
Thank you. Very great work from our colleagues from IPTA, Indonesian Psychiatric Trainees Associations. So these are the faces of our future psychiatrists, hopefully, and and the networking and collaboration has already started during residency. So for participants who are currently psychiatric residents, please join IPTA. That's our sponsorship message from the video. All right, now we are going to move forward to question and answer session. We have maximum 30 minutes for this session. And I would like to welcome questions from participants, from audience, questions that will be addressed to either Professor Sartorius or Dr. Natalia Widiasi, or perhaps to our previous speakers, Dr. Hafid or also Dr. Karina. I already have one question here that I'm going to read. This is a question from Dr. Ariel Nugroho Susanto. The question is there any possibility for psychiatrists to have virtual practice license? So a psychiatrist can work anywhere. So not at one particular place, but this is like a virtual practice license. So the psychiatrist could work anywhere. I would like to ask response from Professor Sartorius first.
I am not aware of that. I think that the virtual reality is still in most places used as an experimental treatment. And it is very rare that, in fact, it's not sufficiently, I think, distinct from other forms of psychiatric treatment. So for the moment, I'm not aware of any country that has provided a special license for a virtual therapist, virtual reality therapist.
Thank you, Prof. Dr. Natalia, would you give your comments to this question?
Maybe I think I haven't heard also Dr. Fisha about this kind of issue. According to IPTA, every doctors could practice everywhere if they have capacity and have ability to understand and have a skill to help people. And sometimes as a psychiatrist, we should also know about the culture or the background of the patient, of our patient. So if there is, the question is there any virtual practice license? Should be, the license could be given to the people, but there is also should be a board, a member of board in the world to examine that whether we are as a psychiatrist eligible or have the skill to help people with around the world. So it's a question again, do we have the capability to help every individual with our limitation of knowledge or skill? Should be aware of that as a ethical consideration, I think. That's my comment about that, Dr. Sylvia.
Thank you, Dr. Natalia. Yeah, I think the growing technology used in psychiatry services needs also like proper rules and regulations, of course, to protect us as service providers in giving services to our patients. I would like to continue to our second question. Okay, this is from Melanie. Melanie is from Puskesmas Cikidang, Sukabumi, West Java. So the first question is referred to the first speaker. So this is for Dr. Hafid. How many times the virtual reality is applied to get good result for acrophobia? And there is a second question from Melanie. The second question is for Prof. Norman Sartorius. Ideally, we should treat patients as well as we can. But as psychiatrists at primary health care, we face a big number of patients. So the question is how to treat patients ideally, but still effective Especially in digital era, patients are more curious with many questions and information from the internet. I would like Dr. Hafid first to answer the first question about virtual reality.
Thank you, Dr. Vivi. I think we don't have any data yet because we still implement this technique about virtual reality therapy using healthy subject. We still use voluntarily for healthy subject, and we feel more adverse effect, to be honest. We feel more dizziness and also disorientation when we try to fit the Oculus for virtual reality, and then we try to reorientation our eyes or in these 3D modules, and when we take off the goggles, and we have to reorientations again with our surroundings. So I think this should understand more about this, and we still in development about the technique. Just as referred to Prof. Norman Sartorius and Dr. Natalia, we should understand that about the ethical clearance using this new technology. So I suggest this new technology is only for added value in our traditional psychiatric practice, because we should strict about the method we use for the patients. So we haven't added more adverse effect for the patients, and also we need to prove this method is very beneficial for the patients. Thank you, Dr. Vivi.
Thank you, Dr. Hafid. So I think we need more data from research and studies. And I was also wondering whether we can also use virtual reality to past trauma, patients with past trauma also. But it must be, I think it should be tailor-made, to each patient. So that's one thing to think about together. All right, I will give the time to Prof. Sartorius to respond to the question about giving ideal psychiatric service in a non-ideal setting when we have so many patients. Please, Prof. Sartorius.
Yeah, well, that's a question which we had for a long time. For a while, we were saying, let us try to think about ways in which we can pass the patients on to general practitioners, and maybe GPs or other people can do something. And by and large, this sometimes works, but usually. Sorry, can you hear me?
Yes, Prof. Participant, please keep your audio muted so we can hear Prof. Norman clearly. Go ahead, Prof.
So this was one of the methods that has been proposed to, so to say, it was called task shifting and task sharing, etc. But that does not really reply, because even if we enable general practitioners and nurses and midwives and others to deal with some of the problems which they encounter in their daily work, it will be necessary to really think of a different way of training GPs to achieve this. Now we are coming back to the psychiatrist who is very busy, has many people to see. What can he do to be a better person? And I think that for many patients, it is more the quality of the encounter is more important than the amount of time that you give them. It is the way in which a patient is seen, received, listened to. For example, I've seen psychiatrists who are making notes on their computer while the patient talks to them. We have measured to see how long a psychiatrist allows the patient to speak before he interrupts the patient. 20 to 30 seconds, after which the doctor starts interrupting. These are things which can be corrected. I think that to try sometimes in your own thing, you will be surprised. Try to listen to somebody for 2 minutes, and you will see how much more you will hear if you don't speak. Normally, we are trying to guide the patient. He says, he comes to you and says, I have a great headache. And then you say, where is it in front or maybe in the back? You're not allowed him to say what in fact he wanted to say. He should be given the respect and the time to speak. So I'm thinking that it's very difficult to give you more time. But what can be done for the patient, since there's very little time, is to improve the quality of that time significantly. And I think that the skill of listening is one that is unfortunately not trained. It's not a part of our training, but it's a very important skill that one has to develop. A skill of listening is not being present while the patient speaks. A skill of listening is understanding what goes on and trying to listen, and the patient will feel whether you're listening or not. So there are other things as well which one could do to improve the quality of the time that we have. So I think that that's one answer, one part of the answer to the question. The second part of the answer is, of course, that what we have seen in recent are you listening? Can you hear me?
Yes, Prof, clearly.
Yeah. There's some Citra Bitri has come on the screen for a moment. Right. I have a question, however, which I got, and if you allow me, I will just mention this point, which is a little different from the question, but it in part answers to the question of our colleague. You have mentioned that you are in contact and looking at the European Federation of Psychiatric Trainees, and the European Federation of Psychiatric Trainees is in fact an organization that brings together psychiatrists who are in training, and once they complete their training, they stop being members. They are then no more members. And I think that's wrong. I think that one should think of the psychiatrists early in their career, and while the people who are still in training will be meeting with the association, the older members could also join and should be invited to join and come along and be present, maybe as the alumni of the school, so to say, that they would have maybe half a day in which they will meet with the younger colleagues and develop a little bit of a collaboration and also speak to them about their experience. I think that the limitation that the European Federation has introduced is not very helpful. I think that they should have a possibility. The Japanese Psychiatric Association, the Japanese Association of Young Psychiatrists, in fact, invites the more older members to come back and to give a talk about something they are doing, not for much time, but to come back to the group and to help the younger colleagues. And I think it's a much better model. Now, there's one other question I wanted to make, point I'm going to make. And that is, I just tell you about one of the uses of virtual technology and technology in general, which is underused. And I'll illustrate this by the story of many years ago. I went to a country in the south of Africa, and this is Lesotho. It's a small country characterized by mountains of enormous size, and it's very difficult to get from one mountain into another. So these people who work in these areas are very lonely. And many of them have been lonely, and then they have invented a thing which I thought was nice. On Monday morning, a doctor in the center had his radio. This was at the time the radio was. He opened the radio, and a person from the periphery could ask a question. The doctor was there for 1 hour on Monday morning so that anybody who had a question could phone in and ask the question. Now, it was immensely helpful. I spoke to the people in the periphery. He says, sometimes we are lonely, we don't know what to do. We have nobody to ask for advice. And here was then we can phone. We know that on Monday, well, it does Monday, it could be any day, I can phone and there will be somebody who can help me. And I think that it would be nice if you, the more senior and experienced persons in this association, could say that there would be a day or 2 or 3 in which there would be 1 hour for questions of the young people who do not know something or would like to have some advice or some question or something like that. It's a, so to say, an hour of questioning which would be available to people who are very often, I presume in Indonesia as well, quite isolated and far away from one another. So that's a suggestion I'd like you to maybe consider about having a, so to say, a regular use of your internet technology, in that you can, you know that on Tuesday, I will have half an hour in which I can ask a question of Dr. Hafid, because he is free for me on Tuesday morning for half an hour. And this kind of a mentoring system in which people would be willing to give advice would be established with the current technology very easily. I'm sure it's completely on a voluntary basis on both sides, but I think it will be very helpful. It's a fixed time at which you know that you can get somebody, that you know, I'd like to speak to to be with Dr. Melia on, that is a specific time at which I can get them. Just a suggestion which you might wish to consider in thinking about the future.
Thank you, Prof. Sartorius. I think that is a very great idea, because nowadays, I believe young psychiatrists and also trainees could do that with Instagram Live. So they use social media as well, Prof, to give like a question and answer session with people. So that's amazing. I think Prof. Sartorius has pointed out very important aspects to the question about the time management skills and active listening skills. Those are the skills that we need to improve, to master, to provide psychiatric services, especially in places where we see a big number of patients. I would like to ask Dr. Natalia. Perhaps Dr. Natalia would like to give response to the previous questions about providing effective or ideal psychiatric service where we see a lot of patients with limited number of time.
Actually, when dealing with telemedicine as our tools to help effective practice, so we should choose the eligible patient also, because when we see the new patient, telemedicine is not quite recommended for that, because sometimes we know nothing about this patient and how many time or how much burden that this person have. So to make the telemedicine is effective and efficient, could use to our old patient, just maintaining the condition that the patient already stable. I think to choose wisely when we use some kind of technology to the right person is one of also make the technology is better or optimized as a source of useful tools for us to optimize our daily practice. And then also the as I said before, the readiness of our facility to provide the specific technology is quite important, because we cannot make a good communication with the patient, or the quality relationship is make better with this kind of technology if the quality of the resources of the technology is poor, something like that. And also as the patient as the same, because it's two to tango. The communication is not only in our side, but in the patient side is also, you should consider, is the in the house of the patient is ready and the situation is conducive for the situation to make the treatment run well. That's also should be considered when we want to make technology as our part of our daily practices. Something like that, Dr. Vivi. Nice.
Thank you, Dr. Natalia. Yes, otherwise we will spend or waste our time because of technological issue or technical issues. So we need to consider those things. And also for first intake, first meeting with patient, that will take longer time. So maybe it will consume our time more than our regular patients or maintenance patients. Let's continue to our next question. This is from Nafsa, psychiatric resident from 11 Maret University, Surakarta. She's really interested in the presentation from Dr. Karina about curhat sesama sejawat. Okay, so this is like peer counseling. Can you please explain more about this? Is it free for all residents? Is it all online or offline practices? And what exactly the psychiatric residents are doing in this project? Only screening for psychopathology or also giving treatments and prescription? So this is a good question for Dr. Karina. Perhaps Dr. Karina can explain more about this.
Thank you, Dr. Vivi. Thank you, Dr. Nafsa, for the question. So regarding the peer telecounseling, this is actually a project that is headed and supervised by the community division in our department, in the psychiatric department, in our hospital and our university. The residents who are in the community rotation, who are senior residents, that means that they are in the last stage of their psychiatric residency, are the ones who are giving counseling. And they are also being supervised by through after the consultation. Usually the residents make a report and they report back to the head, to the consultants of the community division. It's free, and usually we share it between residents, between the chiefs of each of our departments in the hospital, and it's online, and the consultation is usually through a WhatsApp call. So sometimes they use the video call, but usually it's only a audio call, and it's actually performed one time per week, but the registration is open for a whole week. And to maintain the quality of the consultation, there's a limit of four people who can be consulted on that specific day. And usually regarding the treatment, because it's not through a system and through the hospital, we can't prescribe anything. So basically we optimize the supportive psychotherapy through that consultation. And if we also do the screening at the same time. If we see that they have psychopathologies that are quite severe, that need further consultation, we usually tell them about the services that are in the hospital that are open for residents, and also regarding the schedules and how they can register officially as a patient in the hospital, like that. And regarding the privacy, this is sometimes I myself, I have a lot of friends. This is actually personal experience that other residents feel they don't feel free to talk to other peers. They feel scared that maybe their department will know, maybe it'll affect their academic problems. But so far, we've maintained a good privacy, and we've actually helped a lot of residents to get that they are referred to the official psychiatrist to get further care.
Thank you, Dr. Karina. Yeah, I think this is a very good example of practices, because we know that there is an increasing number of burnout cases among residents, and we know that there is a high prevalence of depression among residents and medical students. I would like to ask responses from Prof. Sartorius and Dr. Natalia about this peer counseling or peer support for us as psychiatrists or psychiatric trainees in particular. Prof. Sartorius.
Well, peer counseling has been seen as there are three ways of talking about it. It's first peer counseling in treatment, in which the most experience has been obtained in people dealing with people who had alcohol problems and who have managed to get rid of these problems and then volunteered to help others who were addicted to stop and being with them and giving them company and encourage them and so forth, and helping them to re-enter normal life. And that worked quite well and gradually also expanded a little bit to also to non-narcotics, dependence on narcotics and drugs. The great breakthrough was in fact the peer counseling and peer support in the field of physical illness, where, for example, patients with diabetes have become peer counselors, and there are world programs and other programs in which a person who has had the experience of illness helps another one to work, this coupling is done by the doctor, who, after he has treated some people, may wish to explore with the person whom he treats after the treatment is over, whether he'd be interested to help somebody with a similar illness. And many patients, in fact, will in fact say yes, provided that there are some limitations. But it is possible to sort of to pair people. If you know your patient number one, you know your patient number two, sometimes it's possible to tell them, all right, so why don't you do something together? And one can visit the other or speak together. One of the chief problems of our society today, it's not, I hope, yet in Indonesia as much as in other countries, is loneliness. Loneliness is such a bad problem that the British government has just a few months ago created a post for a Minister of Loneliness. And the Ministry of Loneliness is supposed to help people who are lonely. 30% of all people in London, of all households in London are single-person households. There's only one person living alone. And not only is he living alone, but he has no contacts whatsoever. So that the peer system is in fact overcoming this problem of loneliness. It's also helping people with practical advice and practical suggestions about what they can do and so forth. Now, with time went by, peer support has also been introduced into the medical field. So the doctors help one another. A younger colleague finds another who has just finished his degrees and who, so to say, helps him and guides him. He's not a mentor, it's really more a peer, because they're not very distant from one another. And that has also been introduced as in previous times you would speak about friendship that has been created. But the size of the institutions and the size of people has been so vast now that probably some of these more artificial ways of creating mutual support have become necessary. So I think the peer support is, and I'll tell you how enormously useful it is by one example. This is many years ago, I visited a facility in Panama, and there is a doctor who is a gynecologist, and he has requested, normally he would accept the ladies who came to have a childbirth to the clinic in which they were, it's a maternity clinic. And then he also asked peers, that is a woman from the village, to come along and spend the 74 hours, more or less, with the person, with a woman who was about to have a baby. They could talk, they spoke about whatever they liked. He didn't give them any instructions or anything. They were together. And the curious thing that happened after that was that the length of the childbirth has been reduced by 40%. The duration of the childbirth. It's nothing to do with, there was no intervention on the part of the peer, except that the peer was present. And so it led to a relaxation, a bit of advice, a bit of decompensation, etc. All of this was very helpful. So I'm all for peer systems because we have lost the construction of communities which made friendships so easy. We are now in a different world where friendships are not easy to create. And so we have to create them artificially by peer systems.
Thank you, Prof. Sartorius. Dr. Natalia, could you please give your
Thank you, Dr. Fisha. I guess I just talk about peer support in RSCM. What Dr. Karkal mentioned before is very useful for our resident or even for our clinician when dealing with pandemic situation. We dealing with situation, uncertain situation, and all the clinician at that time is very afraid and confused before because they have knowledge about what to do with this situation, how to deal with people with so many problems around them, and they should stand for helping all the patients who come and all the family with their uncertain situation. It's very difficult for everyone. So this curhat session with peers is very important for us at that time because it's being a safety place for us to be venting, to catharsis all what we feel, what we see, and we could talk everything just safe and feel support, and they feel being understand it's okay to be not okay, it's okay to be not knowing what to do at that time. And after that we talk each other how to deal with the new situation with having this safety place for venting and debriefing or our psychological at that time. It's help to prevent burnout at that time because sometimes dealing with uncertain is not quite easier for everyone to deal with. So having peers to support each other, having safety place to being not okay is okay. It's kind of something helpful at that time. And after that, we talk each other and we learn together how to deal with the situation, and we come up with some ideas how to back up each other to manage the situation, something. And this kind of module that we have like peer support is continuous. Even the pandemics already start for 2 years, but we still having each other back at that time because the situation always changes. And I think this is a good module to have in every place, to every hospital or every health care to have this kind of program to have prevents burnout when dealing with something traumatic or something new for us to have a psychological debriefing. I think that's my opinion, Dr. Pisa.
Thank you, Dr. Natalia. yes, I think it should be continued and applied to different places, different centers, and probably not only for trainees, but also for early career psychiatrists, or also even mid-career psychiatrists who need, peer support because of the burnout and also the burden of work as a psychiatrist. It's been a very fruitful session, but I'm afraid I have to summarize our meeting for this evening. We have already discussed about digital technology in future psychiatry. We have heard the work that Dr. Hafid and his colleagues done at his workplace using virtual reality for phobia cases. And there are things that we need to consider while we use this kind of technology to treat patients, because there will be pros and cons, and there are certain things that we need to be mindful about when we are using virtual reality. And we also heard Dr. Karina presented about the work in RSCM, the work using telemedicine or telepsychiatry to provide psychiatric consultation and also supportive psychotherapy during the COVID pandemic to patients, to families of patients, and even to other residents or to peer. And I believe that we have learned a lot from Prof. Sartorius and Dr. Natalia about aspects of time management skills, about quality is more important than the amount of time given to our patients. Also the aspect of ethical, medical, legal that we need to consider. We need to be mindful when we provide services using technology or digital psychiatry. And I believe this is something that is going to grow more and more. And us as future psychiatrists, young psychiatrists, probably will deal with this digital technology more and more in our practices in the future. Before we close our evening session, we are going to have a photo session. So I hope the committee will help with the photo session. Participants, if you are willing to turn on your video, your camera, so we can see your beautiful faces and have a wonderful picture together. Committee from IPTA, can you help for organizing the photo session?
Maybe Dr. Sarah or Dr. Stephen could help us to capture the screen.
Okay.
For
Sure.
the first screen,
Yeah.
1, 2, 3, and the second screen, 1, 2, 3, and the third screen, 1, 2, 3, and the fourth, 1, 2, 3, the fifth, 1, 2, 3, the sixth screen, 1, 2, 3, the seventh screen, 1, 2, 3, and the last one, 1, 2, 3. Thank you.
Thank you. Thank you very much. And I would also thank once again and foremost to our beloved Professor Norman Sartorius. Thank you very much, Prof. We are very delighted to have you with us. And to Dr. Natalia Widiasi, thank you very much, Dr. Natalia. And to Dr. Hafid and Dr. Karina, thank you for your presentations, and to all committees who have worked very hard to make this event work. and to all participants who have stayed until the end of the meeting. And I believe that we will have more and more sessions like this, more series, international webinar, a joint event from IPTA and Indonesian ECP. I will give back to the host, and I'm very honored to be the chairperson of this meeting. Thank you very much for your attention, and good evening. Good night, everyone.
Thank you, Dr. Visa. Thank you, Prof. Norman.
Thank you, Prof. Norman, Dr. Natalia. Terima kasih.
Thank you, Dr. Natalia.
Halo, Prof. Marlina.
Dr. Karina.
Thank you, Dr.
Kangen, Prof.
Prof. Marlina, terima kasih, Prof.
Thank you for the chairman for excellent chairing.
Thank you, Prof.
Thank you, Prof.
I'm your student. I shouldn't be.
You've done very well. Very well.
I should practice your course. Thank you, Prof. Thank you so much.
Sehat, Prof. Prof. Marlina.
Oh, begitu lihat kalian sehat. Penyembuh lihat yang muda-muda.
Mudah-mudahan minggu depan udah ini turun ya, Prof. COVID. Saya ke sana, Prof. Mau main.
Banyak teman sejawat yang MRS.
Oh, iya, Prof. Lagi ini ya,